Good morning. I'm Kirsten Singleton, Executive Director of Education and Professional Development. And on behalf of the Massachusetts Health and Hospital Association, welcome to today's webinar, What's Next in Healthcare Innovation? And actually, it is good afternoon. That's what I meant to say. A few logistics before we start. We will be recording this session for those who aren't able to join us, and all lines will be in listen-only mode. If you have questions during the webinar, we really encourage you to enter them into the chat feature. The questions will come directly to us, and we'll do our best to address as many as we can during our time today. Following the webinar, we'll be sending out the slides along with a brief survey. We'd love to hear more about what you'd like to hear for future webinars. I also want to take a moment to thank MHA's 2021 sponsors for their support in underwriting today's webinar, which is part of a series we're doing to bring experts to our members to help address timely issues relating to the COVID-19 pandemic and other hot topics in healthcare. And I'd also like to give a special thanks to our session sponsor today, Dimensional Insight. We are partnering with Dimensional Insight throughout 2021 to bring you a series of webinars focused on analytics and emerging technologies. Now, I'd like to hand it over to our moderator for today's session, Kathy Suchik, Vice President of Marketing at Dimensional Insight and host of the Smarter Healthcare podcast. With that, I'll hand it over to Kathy.
Thank you, Kirsten. I am delighted to be here today. As we all know, digital health expanded exponentially in 2020 during the global pandemic. As new vaccines and treatments provide hope that normality of some sort may resume in 2021, breakthroughs enabled by the accelerated pace of innovation will better equip us to face new challenges. With telemedicine now adopted widely, what other types of health technologies are emerging faster than we may have thought possible just a year ago? And how will they change the patient experience? In today's program, we'll hear from digital health and technology leaders and learn more about how technology can inform care and promote health. We'll also hear about emerging digital infrastructures being created to better serve patients and keep up with the pace of technology. What types of home technologies and wearables are gaining traction? How are hospitals using AI applications? And what will healthcare look like in the next few years? Now I'm pleased to introduce our speakers today. Dr. John Brownstein is the Chief Innovation Officer at Boston Children's Hospital. Dr. Brownstein was trained as an epidemiologist at Yale University, where he received his PhD. His research interests are in the development of methods and data sources in public health informatics that focus on two major areas. One, the design, evaluation, and implementation of public health surveillance systems. And two, statistical modeling of public health surveillance data to improve prevention and control activities. This research has focused on a variety of infectious disease systems, including malaria, HIV, dengue, West Nile virus, Lyme disease, RSV, Salmonella, Listeria, and influenza. Dr. Alastair Erskine is the Chief Digital Health Officer at Mass General Brigham. He is responsible for sequencing innovative technologies, harmonizing data across the clinical care, research, and health plan enterprise, and aligning digital patient experience with emerging patient consumerism trends. Dr. Erskine leads the Digital Health Department responsible for the design and configuration of Mass General Brigham's clinical information systems and virtual care services. He also leads the Enterprise Data and Digital Health Program, a targeted 5-year initiative to advance foundational investments in digital patient experience, system operations, and clinical care to enable Mass General Brigham to engage across local, national, and global markets. Dr. Yiding Yu is Chief Medical Officer at Olive. She is a practicing physician and serial entrepreneur, passionate about transforming the way we imagine and deliver healthcare. Named Woman Entrepreneur of the Year in 2018 by the Cartier Women's Initiative Awards, Dr. Yu is a skilled business operator and passionate public speaker who has launched and scaled innovations across the healthcare ecosystem. We're delighted to have you all here today. So I'd like to kick off our conversation by first asking about some of the lessons of 2020 before we start looking to 2021 and beyond. John, let's start with you. What were some of the lessons that you and your colleagues at Boston Children's Hospital learned about innovation from 2020?
Yeah, I mean, thanks so much for having me. It's great to be part of this session with these great colleagues. Obviously, 2020 was a bit of a game changer. I mean, we've been setting up an innovation platform and digital health efforts at the hospital. I've been Chief Innovation Officer for 6 years, and we had been pushing some of these concepts for a long time with limited or I guess a medium amount of traction. And so this emergency really in many ways catalyzed the changes that we have been seeding for so long, right? The idea that finally these stakeholders that there's clearly different motivations, but clinicians, researchers, business leaders now all could come together in the wake of this pandemic to sort of push all this incredible innovation. And not only just within the hospital, but our team is hyper-focused in innovations that have impact both nationally and globally. I mean, hospitals themselves are not known for their agility at all, but I would say in 2020, we were. And the hope is that we continue this. I mean, we were able to repurpose our accelerator to prioritize COVID innovations and ideas in a way that we had not seen before, right? So we were in a whole range of areas, whether it's 3D printing of swabs or thinking about new ways of providing respirators or building technologies around contact tracing, new protocols around patient management, chatbot-like tools, which I know on the partner side, we collaborated pretty significantly with. And then the bread and butter, I mean, the ability, we had a telemedicine program that had been ongoing for years, but, we were providing that, virtual visits on a daily basis that, had the same scale as, the entire previous quarter of 2019. And so we were able to sort of get scale in some of the areas in which we didn't have scale, and we were able to implement technology in places that we've been waiting for so long, like things as basic as digital intake of patients and trying to create synthesized ways to make it easier on our patients. So, we'll talk more about some of these innovations, but clearly, 2020 was sort of a massive catalyst for all our operations.
Great. And Alistair, I'll ask you the same question as it relates to the lessons that Mass General Brigham learned from 2020.
Yeah, so not all that different, in fact, with my colleague, Dr. Breinstein, but I think the need to be able to create applications in real time on the fly as sudden processes and workflows were required that were different than previous became a really important capability. Of course, the virtual care aspect as well. We went from about 1,500 virtual visits a month to somewhere around 250,000 a month. So clearly something that needed to be done at scale. And we saw some of the legislative and financial barriers melt away as part of the emergency needs. But we saw some other things come into focus, which was really some of the digital divide problems that have been there lurking the entire time. And so reaching out to patients, especially the ones that were most vulnerable to COVID, became a really important and collaborative effort with the community to make sure that we were able to not just assume that people had a smartphone or a desktop computer and an internet connection and the savviness on how to use it, but were able still to use other means. Texting became very important, outbound calls and call centers became important. And I think the other thing that was really important as information was coming in and we just didn't know where the surge was gonna go, was situational awareness across our entire system. Sort of damage report to the battleship in terms of as people were coming in and ICUs were filling and we were missing PPE and ventilators, and we needed to make sure that we were capable of reacting quickly. So being aware of the supply chain, buying an iPad, in March was a little bit challenging. Getting just like PPE, making sure that we were aware of the capacity of our hospital ICUs and beds and our staff. That situational awareness became important, and so a lot of technical debt was created on the fly as we created dashboards that sometimes were a bit manual on the back end, just to make sure that we were serving up that information. And then over time, we converted that to something that was more automated. I think the last area that became important for us is and all of us is remote patient monitoring strategies. So the need to admit a patient to the hospital could sometimes be obviated by making sure that the patient had good follow-up with a good remote patient monitoring system to be able to keep track of their ongoing symptoms, their oxygen saturation, you know, and any other things that were happening to them. So that also became a part of our plan, is to make sure that we understood ways to avoid hospitalization when it wasn't necessary, when we could use digital technologies to be able to offset it.
Great. Those are some great insights from the health system perspective. Yiding, what about from the technology provider perspective? What are some of your biggest lessons from the last year?
Yeah, well, certainly I think huge props to all the healthcare organizations and just the amount of movement that happened in such a rapid year. I'm a provider myself, and I remember, you know, during the early days, every day we had a new COVID protocol. It was just getting better and better and better, and we were dynamically, you know, reflecting on what was going on in our local community. And so certainly they've proven that large organizations can move fast. But on the innovation side, as a vendor, you know, we sell primarily to health systems, and so when, you know, organizations realized that they were not going to see patients and they were freezing their revenue and furloughing workers, it was, you know, it was certainly daunting, because we certainly had to say, we had all these projections of what we might deliver. What is that really going to happen to our business? And I think, you know, we know that if you were a telehealth company, if you were COVID testing or anything that's related to the current state of events, you did well. Like, you saw a huge boom in the industry for those technologies. But maybe also quite surprising is that anything in the revenue cycle, anything that helped reduce administrative burden, that helped improve the efficiency of an organization, also saw a boost. And so, you know, at Olive, we are focused on automation. So we develop healthcare specific artificial intelligence and deploy AI workers as well as AI sidekicks. So imagine, you know, automating behind the scenes activities or patient intake type activities for COVID. Imagine, you know, if you're scheduling a patient, having, you know, an assistant right to your side that says, oh, you know, Dr. Yu doesn't see telehealth visits on Thursday. She sees them on Friday mornings and Friday afternoons, like book accordingly. Instead of having to look through different spreadsheets, going to different websites to find it, you can actually put it all together. And so because of our work in streamlining administrative waste, we actually saw a huge increase. We actually beat our targets last year and ended up raising, at Olive, raised nearly $400 million last year to fuel this growth, which we're continuing to push forward. In the metrics that, you know, our clients and we hear so much of are demanding are, you know, how can you reduce my administrative burden and free up my workers to do, you know, what they need to do, especially if they have to work from home. And then how can you reduce my denials and things that might be causing me to lose money? And lastly, how do I get, you know, how can you help me get patients in the door in ways that, you know, used to be more manual, more time consuming? How do we, you know, leapfrog past the usual way of doing things and get patients care and get that revenue back into my health system?
Now, given the pace of change in 2020, do you think it will be easier to innovate moving forward, or do you think there are still significant hurdles that the healthcare industry will have to overcome? Alistair, let's start with you for this question.
I'd love to put on my rose glasses and believe that the challenges associated with implementation of digital technologies will lift and all of a sudden people will embrace. Unfortunately, I'm a bit more pessimistic, and I think you know, healthy skepticism always embraces new and creative ideas on how to change workflow. I do think it's clear that whereas, you know, something like trying to make the case as to why virtual care makes sense, that has lifted significantly as both clinicians and staff have digitally upskilled, but also, and importantly, patients are beginning to digitally upskill as well to these new kinds of technologies and appreciating them. So I think that's going to be easier to make the case. But I think, you know, and just like Dr. Yu was talking around, you know, the automation piece, we've hired a number of, so to speak, hired a number of digital employees that sit next to us. You know, The beautiful thing about them is that they work 24/7. They don't ever take vacation. So they just need a little bit of a tweak to be able to function. In some few cases, when we didn't do it just right, we had to fire them because they were going rogue and doing things that they weren't supposed to. Or maybe we had changed the workflow under them and they weren't prepared to be able to make those kinds of swaps. But anything that we can do to reduce the dependency on labor, in the healthcare system makes our entire system potentially more efficient. So I think we'll see still some healthy skepticism, but I think that there are a few key areas that likely will get loosened up a little bit.
Gideon, what do you think about this question?
Yeah, I mean, I'm a realist as well, but I'm also a true believer that we can, always move forward. And I think we've learned a good amount. I mean, I think one of the cool things that we've seen is that sometimes the best innovations do not have to be like huge enterprise projects. Those take a long time. It takes months, if not a whole year of IT work. And so what I'm really excited about are what are the lighter lifts. So what are the things that we can start doing that maybe democratize the access to these digital health tools. And so I think that companies that have thought of ways to actually help in and plug in and pretty lighter touches, those can really take advantage of the situation. Though of course we'll always need the ones that are deeply integrated, deeply connected. That works as well. I'll just give a quick example. Olive launched a platform called Olive Helps. And what it is a small desktop application that sits on top of your computer, does not need to be integrated into Epic or an EMR, but you can design these loops that provide whispers. And so essentially what it's doing is it's understanding what's happening on the screen or where you're clicking or what I'm reading, and then it will find the right information at the right time. So I think of like Jarvis for like Iron Man, right? Like how does it take contextual clues and present information? And when we launched Helps, it wasn't a view of Olive to build everything. So there are some, functionality that we're building for our clients, like, the telecom support, but we're also partnering with a vast array. We have nearly 100 digital health partners who are some of your coolest digital health companies out there who can build loops into this ecosystem. So it's almost like you have an app store of different applications. So if you're looking for patient engagement at the point of care, if you're looking for care management protocols like help you with nurse triage, if you're looking for, does it require a prior auth for the person who's going to schedule a procedure, all of these whispers can come into your workflow without kind of doing the traditional EMR integration. And I think if we do it right, it can really leapfrog a health system's access to a far range of innovations that they can kind of plug and play.
And John, how would you answer this question?
Yeah, I mean, I think, my colleagues have touched on some great points. I think, I'm probably in the middle of being optimistic and having still some concerns about, whether this is just a point shift. We, I think, have built a real foundation and sort of this institutional muscle for telehealth. I think that will exist, and I think it will persist. And I think what will happen is it will push us forward into other areas. I mean, I think Alistair mentioned the opportunities around remote patient monitoring, and that one is a huge priority for us. The ability to leverage connected devices to really do longitudinal virtual care management. I mean, we because of the pandemic got funding to work with a company, TytoCare, that is doing the remote patient exam, and we're getting deployment. And because of that deployment and through some of that funding that came, I think that will lead to some permanent changes. I think also, and we can't go through the session without talking about sort of burnout and the overtaxed clinical workforce. This was huge prior to COVID. This is especially true now. And the question is, will that now get us into this moment of AI-enabled care teams? Our team's working in partnership with Nuance on the sort of voice-enabled EMR, the ambient clinical listening device in the patient room that can take that conversation, capture voice, parse out language, and then, populate in the future, populate the electronic medical record. That plus other sort of sophisticated clinical decision support tools, I think, will have a place. And I think now there is that sort of push. I think on the hurdles front, I think there's still the regulatory issues that we're facing. And the question is, do these things change permanently? Obviously, there's the issues around parity for telehealth, and that's not a permanent guarantee. So, we need to continue showing value there. We have issues at our hospital around cross-state licensure. That will, we'll see whether these emergency orders subside, because that, of course, is allowing us to provide care for the most complex patients. And then, we just have to be careful of the health system not to slip back into our old patterns. I have that concern. My team has that concern. I think as an institution, we're worried that, can we now, and we're working hard at this at Boston Children's is this moment now to really push ourselves forward and rethinking our care delivery methods? How do we bringing these digital innovations in permanently? So I think, of course, patients are demanding this. So that's clear. So again, it's definitely some optimism, but I, worry that, without the sort of the trauma of the pandemic, do we just fall back to our old habits?
All right, let's look forward now. So what are some of the most promising healthcare innovations that either your organization is working on right now or that others are working on, but you think will have a significant impact in healthcare in the coming years? Yiding, let's start with you.
Wow, there's so many cool areas. I think one area that has been a huge pain point for everyone, patients, providers, and health systems for a long time, that I think there's going to be incredible work happening that's all going to culminate very soon is in prior auth. We know that it's incredibly expensive. It's the number one complaint from physicians. I saw a report recently that had physicians recording or responding to what is the greatest burden in their administrative work. And it was number 2 was dealing with insurance companies, which that we don't like. Number 1 was prior auth. So I thought if prior auth beat out dealing with insurance companies, which is kind of the same thing, it was a double whammy. So it's clearly a huge problem. And so what we've are working to do is there's a lot of automations that have been deployed, either using rules or using bots. What we've created has been an end-to-end automation platform that actually pulls in 40,000 medical necessity criteria from all the nation's payers, including regional and state payers, and then actually using AI and natural language processing to look through the clinical chart and identify the clinical documents to satisfy that. And so what we're doing, and this is actually live with real providers and real patients, is the next level, which is to provide automated point of care approval. So this is complex, orthopedic surgery prior authorizations where the provider side at a press of their button submits full clinicals, checked against AI clinical review, and the payer sends back, if all the medical necessity criteria are met, sends back an automatic approval back into their EMR, and that patient walks out the door knowing that his knee replacement or her knee MRI is going to be immediately approved. And it's done not through modeling. We're not trying to predict, what that doctor did before. We're actually looking at the clinical documentation for that specific patient and that specific moment to make those decisions. And there's huge appetite to do more of that, to bring these decisions more towards the point of care. So rather than, the faxes and portals that happen today. So I think there's more work in that. And I think CMS is also coming out with a lot more push to try to digitize this, requirements for payer APIs, looking to, deploy FHIR for prior authorization requirements. So it is an exciting field. I think there's a lot of groups who are doing good work here and putting, and the real nirvana, I think, is getting to that point of care authorization, which is, what we're focused on delivering and what we're delivering, to patients today.
All right, John, what do you see as some of the promising innovations right now?
Yeah, listen, there's a lot we could get into. It's hard to sort of boil the ocean of all the things that we're doing. I'll just maybe touch on 2 things. One, maybe more mundane, but super important. You know, we're a 2 EMR a system with both Cerner and Epic, and the challenges of data flow between those. And so I think getting to Yiding's point about FHIR and interoperability those are things that are so important to us right now, given that we're trying to maintain these systems that don't usually talk to each other. We invested in work with a company called Commure, which is basically building the sort of the software layer that sits between our electronic medical record and applications that can help improve usability and so, you know, our goal, and this is, you know, concepts that have come out of Boston Children's for many years, which is this idea of sort of app-based economy when it comes to the electronic medical record, and being able to work more efficiently with companies like Olive to integrate more seamlessly. And we spend huge amounts of time figuring out how to do integrations that, you know, weigh us down and really prevent us from working with the best-in-class startups. And so we've been, you know, over the last several years trying to build that foundational work. It's not the most thrilling, but it's super critical. And I do think, you know, in some ways, my view of the electronic medical record companies start to become more like, you know, just databases. And of course, the sort of the innovations that where startups can sort of exist on top of them more seamlessly. We get to sort of pick and choose the best in class software. Again, this is a concept that's not super new, but we're finally seeing the light at the end of the tunnel with that. I'll just mention one other thing because it's more close to my team, is that we're having impact sort of outside the hospital through just our work on the pandemic, through a variety of different efforts to support the global response. One of those is a technology that we're launching probably within the next week or two, which is called Vaccine Finder. And essentially, we are working with CDC and the White House to build essentially the platform that allow people to figure out where to get COVID vaccine in the community, working with every, you know, Walgreens and CVS and Walmart. And so this is going to be the top layer navigation tool for every patient who is desperate out there looking to get this vaccine. And there's been a sort of a void of federal systems that allow for that knowledge and to sort of guide people to appointment booking. So again, that is maybe outside specifically the hospital, but it's a technology that the hospital is built and, you know, partnering with the CDC to finally launch. So just leave it at that. Thanks.
Great. And Alistair, what is your organization working on?
So, yeah, so I completely agree with the negative net promoter score for prior authorization. So I'm glad that my colleague is working on that, because that is something that is a burden, and a number of different, you know, sort of administrative functions that sort of pollute are sometimes processes that involve the human being serving as an interface between different fragmented systems. So, you know, advancing that mission is a really good mission to advance. I think that the concept of the app economy is a really important one. And it's one that kind of came about as a result of the consolidation of electronic health records, when in the sort of early 2000s, you had sort of ball and twine of interfaces of different separate systems. And really the solution to that was to say, well, let's put everything into one database. And in so doing, it solved the issue of interoperability between various different little systems, but it introduced a scenario where that innovation on the edge and on the fringe of maybe a subspecialist or even a more common workflow that wasn't high on the agenda, wasn't possible with the large EHR vendors, just became more and more difficult to introduce. As somebody who's responsible for keeping the systems up, you want to also make sure that you have as least complex a system to manage, because when something goes bump in the night, you need to fix it immediately and you need to know exactly what's going on. And you can imagine that if in a world full of apps that you don't know how long the company's lived, and you don't know exactly how the company's interacting with the system, and you don't know exactly the thresholds you're setting on top of the API, if you don't have that infrastructure in place to make sure to manage those risks, that can get really complicated. So I think we're learning now with applications like Commure and with standards like FHIR and even FlatFHIR to be able to exchange information between the health system and the payer side, that's now a possibility. The question is, how do we build a business model around each one of those so that they can coexist together nicely over time? We should trend towards a scenario where the electronic health record becomes a bit smaller, and the set of apps that surround it becomes a little bit larger, and it strikes a good balance between the two. I think from there's a sequence and aspect of this that's also important. So, we started digitizing things on the billing side, and then we flipped over to the electronic clinical side. That has some advantages in terms of now we can immediately release results in clinical notes. So almost 100% of our results in clinical notes are being released in real time as soon as they're finalized. That's really important in terms of patient engagement, understanding what happened during the office visit, knowing that your test is negative or positive, having the patient serve as yet another member of the healthcare team to make sure nothing gets missed by making this information readily available that came out with the 21st Century Cures Act. But then all this data being dutifully entered by all the clinicians and staff kind of sits as a mountain of data that we don't necessarily tap into as much as we could. To the extent that we use evidence-based medicine, that's really important. But to the extent that we could use practice-based evidence, like my colleague Chris Longhurst has talked about for years, is also really important to make sure that we can take advantage of the data that sits within our own databases, that is actually not biased against that population, but is actually congruent with our population because it's from our own patients, and use that sometimes in clinical workflow when there isn't an answer that comes from evidence-based medicine. That's a really important part. And so that data ecosystem, to be able to make that happen, the privacy concerns that are associated with that, and how to have your ID doctor consult on the patient, and your AI doctor that consults on the patient, so that you can take this digital twin that you create and be able to understand what are the various permutations that are possible, and then what's the best option for your patient based on your own data. I think moving from electronic health record to data, the next place to go is the consumer relationship management world. A transactional system that's been really missing in the healthcare space, not because we didn't put patients at the center, but just because there was a lot of regulation, billing, and other workflows to have to negotiate and navigate. But I think that is missing, to understand what does the patient want, when do they want to be seen, what was their experience over the past year, what do they want to be called, how do they want to be communicated with in this omnichannel way. That component of consumer relationship management is an important next step. It needs that data to be able to feed it so that it can light up and be useful, and those patient journeys can be mapped out, and those call center agents can receive the information they need in real time, and those networks of physicians can get better assimilated. And then once we have a good understanding and a better understanding of that CRM, it's kind of going back to how do we think horizontally across a population of patients instead of vertically across each individual encounter, from trying to move that care from outside of the hospital and the clinic to kind of the home, to make the total medical expense less, in order to make it more convenient for the patient to engage. We're learning the fact that we get to question our assumptions now in terms of virtual care, letting us know that maybe a patient doesn't need to come in every single time to the clinic to see a doctor. That in fact, that many times it can be done virtually and safely done virtually. Not in every case, but in some cases very much so. So trying to understand, for all these large technologies that take time, effort, that make our system more expensive when we actually introduce them into our cost basis, making sure that we sequence them in a way that they can take advantage of each other, and there's a synergistic relationship kind of going forward.
Great. Now, when we think about some of the big technology companies out there, such as Google and Apple, where do you think they'll fit into the healthcare ecosystem moving forward? Will they be partners to some of the current organizations, or are they more competition? John, let's start with you on this one.
Yeah, I mean, of course, it could go either direction. I mean, we are viewing them as major partners, but of course, the health systems that choose not to partner with these companies could be in a lot of trouble for a wide variety of reasons. I mean, I think generally speaking, these companies are making big bets in healthcare, as we keep seeing in the news, and they will keep sort of chipping away. And the partners that they strike will mean for better, overall, if these are consumer technologies and companies, it will make for better experiences for patients, and patients will likely choose some of those environments to receive care. It makes a lot of sense. As our organization, I mean, we spent a huge amount of time trying to build relationships with sort of these top companies. I mean, with Amazon, for instance, we launched the first skills on the Alexa platform that were directed towards initially consumer information about pediatric conditions and thinking about how to distribute our content more broadly through these sort of new innovative channels. But also now we've brought Amazon into the hospital through a collaboration with Amazon, but also company Ava. And now patients can ask Alexa for all sorts of information about their stay, but also entertainment and other things. And so, and also have a better direct line to nursing. With Google, we actually co-developed with Verily an application that sits on top of the electronic medical record, a clinical decision support tool. Again, having their expertise in UI and AI, of course, is incredibly valuable. And so being able to engage those kinds of resources to direct them to healthcare innovation is incredible. We actually just launched a partnership with Google as well around their Google Health Studies platform, where we can now deploy incredible amounts of research capacity through the Android platform. So we've also partnered with Facebook and thinking about new ways to get information about sort of basic prevention guidelines directly through the Facebook platform. And so, we can just keep going down the list of in ways in which we've tried to partner with them. So our view, of course, is, they cannot directly replace what we do, but they will build infrastructure that there's no chance that we could ever build on the inside. I mean, we have a great engineering team. We find places where there's white space, the things that we can build that can't be done elsewhere. But for the most part, I mean, it's a losing proposition to think that, an engineering team in a health system can build the quality of technology that, these either large companies or well-funded startups can. And so our mission has been clearly partner wherever we can.
Alistair, what do you think about this question?
So thank goodness for other partners that are not directly on the technology space that really are resetting our expectations as to what a patient should expect when they cross the threshold of healthcare system. So I don't have to jump into a time machine and go back 20 years in terms of what that experience feels like. So, and I think that, they'll of course, they'll be nibbling at the edges of our margins, the things that are easier to pick off, not necessarily the things that are mission driven. So there's a really important difference in the agenda that is with, but to John's point, like we can't do this alone, right? We don't want to become a software development shop or an engineering team necessarily. Our primary mission is to take care of patients, at the front line, and so I think partnering with organizations, large technology organizations that can help us do that without us having to become that is really important. Here's the thing, though, that is critical, is trust. And I think people worry about how data flows within our system that's protected by HIPAA, that we that is done in a very kind of careful, respect and privacy way. And then people worry whether it exists or not, whether or not some of the technology companies actually have that same degree of attention, and we worry about trust. So the thing that we've earned over 100 years of, from the snake oil salesman that was selling things off of their caravans all the way to today is a commitment to follow the science, a commitment to get the training, a commitment to take care of the patient and what's ever best for them. And I think that trust has been earned. And I'm not sure the technology companies, all of them, have gotten to the point yet where that trust has been earned. Maybe part of it is because they're new. Maybe part of it is because they've stumbled on the trust issue. But I think that's a key aspect of any partnership, is one that has to preserve the trust that the patient has with the system, so that they believe that we got their back, and then they're not going to be suddenly, in an untoward situation that they hadn't expected.
And Yiding, what do you think about the impact of some of these big tech companies?
I think overall, great. I'm very positive on, because like Alistair saying, I think that, what I expect when I use a Google product or when I use an Apple product is top of line net promoter score. Same thing when I think about Amazon, and not what we're expecting. And so if they can help push the bar that's fantastic. And I'm more biased in that I think consumers are far more likely to put their trust into, using some technologies, whether that's wise or not. I mean, people are streaming their daily lives and just putting it out there. And so, if it's on my iPhone and I get to use it and it facilitates communication, we probably on the healthcare side are just always more biased towards like being ultra conservative on the HIPAA side. I think patients are like, why can't you just email that to me? I've been looking, or text that to me. And we're like, well, can't without your specific written consent and all these other things. But I think it's going to push us. I think it's going to definitely do that. And I think the other trend of this is that all of this virtual care, John mentioned earlier, there's a question of, will we regress? Maybe not immediately, but will we slowly regress to business as of 2019, in some future? I think it's probably our patients who are going to be most resistant to that. The number of people who have experienced a virtual visit and who now expect that option to be available to accommodate a busy day or a busy job, as opposed to, why do I have to come in when I could have just, when last year or last month you allowed me to do it virtually. I think they're going to push us. And I think it's good because they're also going to push their legislators and they're going to push their health insurance companies for the same convenience. And the same, I would say on, use of patient portals, I'm so used to having access to all of my medical records that I can download everything. And there happened to be one test recently that I couldn't download. And that, first of all, really annoyed me because that meant I had to call in and talk to somebody, and then they tried to route me to medical records, and I had to fax in a paper. And then I just said at some point, can somebody just print it out, and then I will physically go to your office. Because I don't want to deal with this faxing, and it might take 2 weeks, and I will physically drive over to Wellesley and I will pick it up, and I will be responsible for scanning and emailing to my other provider because I don't trust you to do this. And yet this activity, just like to get one test result, required like 3 phone calls, like a visit to the doctor's office. And on the flip side, I know that I could have just downloaded it from my patient portal. And that's what I want. I want more of that and less of the old way of calling in, asking a nurse. And that's going to drive a lot of this demand for further, investments in innovation.
God, I hope that wasn't our system. But isn't it funny that we start talking about fax machines and was talking, and that physicians carry around pagers.
Yeah.
That companies are begging us to stop using because they can't find parts for, that we give people CD-ROMs, even though you can't buy a computer with a CD-ROM anymore, in a stack of paper. All these have technology solutions that have been around for a long time. And yet these technologies, these old legacy technologies, remain embedded in our workflow. So,
absolutely. I mean, now, most, I think people will say that, hey, I'll give you a fax number and you can fax it to us. We don't own fax machines. I'm lucky to be a provider, so I have access to a fax line. Most people are going to say, am I going to go to Kinko's? Like, where am I going to go find a fax machine just so I can send a document to you? Because many organizations won't accept medical records through email because it might not be as secure. So, you're absolutely right. I think it's growing and becoming more and more archaic. And I hope our patients kick us into the 21st century.
I'd like to talk about some of the ideas that might seem out there, but that you think might have some potential to have an impact on healthcare. Alistair, let's start with you. What is the most crazy sounding innovation that you think could actually provide a significant breakthrough?
So this concept, which has yet to be materialized, of practice-based evidence, of being able to use our own data to be able to take care of patients that we don't have evidence for, if it ends up manifesting itself in kind of in reality in a way that can be useful, I think that will be really important. I can't just pick one. I'm going to have to pick a couple. I have to agree with John that the conversational interaction is going to be important. If the complaint that I get out of this, and by the way, we survey 200. We do something called trickle feedback in our system. When trickle feedback means you survey 200 people a day, but a different set of 200 people every single day until you cover the entire organization over one period of time, every single user of the system. So that trickle feedback strategy makes sure that we always are getting information about our system. And then we can run AI and sentiment analysis on the sometimes colorful comments that come back and understand what are people most concerned about. And, it's always complexity of the system, too many clicks. I can't find what I'm looking for. There are too many ways to do the same thing. Those are the general types of comments that come back that are really important. And to be able to pull the hands off the keyboard and the mouse and take the gaze away from the screen, and to be able to return that physician-patient interaction back to where it belongs, which is in between the physician and patient with a computer in the middle, that will be a really important advance forward. And so some of the work that some of the companies are doing, just starting in terms of, how do I generate a note from a conversation that occurs between a patient and a physician, to unburden the documentation process, to accurately capture what's actually happening in the exam room, and to be able to then feed and have the ability to say, show me the x-ray, and something gets projected on the wall about a patient without having to click through 15 different tabs. That will be an important part. And I think that there's a lot of technology vendors, including the electronic health record vendors, that are venturing into that space. But that will be an exciting piece to be able to put the keyboard down and just go back to talking to the patient.
All right, Yiding, what do you think?
So something that we're really excited about and we are starting to pursue is something called health assurance, which is to say, how can we, there's so much cost in the system just to confirm that the insurance company wants to pay the right bill, that it was paid for the right procedure, and that, all the other stuff that goes along with it ends up taking, up to 40 some days to get paid for a procedure and the billing, and you have to chase after patient billing. And all that work, right? The amount of people, I know that I'm sure Brigham, Mass General, or Mass General Brigham and Children's employ just to handle billing and billing appeals. That's massive. I know that's the case at Atrius. It's a huge team. And so we're exploring ways to guarantee payment or assure the health of a patient. And so that the moment care is provided, the provider is paid, everything is taken care of. And we can do that, we think, if we have, understanding of the clinical decisions that came up to at the risk of the patient, right? It's like with full visibility of what's happening on the provider side and access to, the payer information. Why don't we go and guarantee that payment for people, and so that we don't spend effort chasing? I think if we can do that, if we make sure that a transaction for healthcare feels like checking out at Best Buy, we can reduce a lot of this hassle that's administrative waste, we think, and just kind of focus on really cool aggressive care. But to do that requires, right, there's a reason why we haven't been able to do that already. To do that requires vast understanding of the clinical data, real great connection with the financial data, and an entity that's able to bear risk. And so we're really excited about that, and something very much looking for AI to help solve and hope deliver that future. So it's a little out there, but I think doable if we do it right.
Great. And John, what do you think?
Yeah, I mean, I think, riffing on what we've already heard, I mean, I think I also mentioned some of the opportunities in changing the provider patient dynamic with, with the ability to extract that conversation and all the opportunities with voice. I'll maybe just riff a little bit on that, because a lot of both an interest on the clinical side, but also on the research side, is this whole area of digital phenotyping, the ability to understand sort of outcomes and potentially identify therapies through sort of digital traces that people leave behind. It's something that we've worked on for a lot of years, mostly in the text-based area where people interact with technology, what they search for online or what they tweet about or like on Facebook. All of that information gives us important signs about outcomes and behaviors. But I think, with sort of the advent of AI and also the advent actually of telemedicine, we can move into this whole arena of sort of biomarkers, whether they're voice-based or visual. There's incredible vast amount of data that we're sort of leaving behind in all these sort of telemedicine visits. Of course, you're having an interaction, but through AI, you could be measuring physiology and vitals. There's opportunities to monitor sort of cognitive decline or emotional state, disease states. There's incredible sort of small sample size studies that have shown that you can get deep insights into a wide range of diseases just by sort of either monitoring voice, so the rate, rhythm, the features of the tone of your voice, or through machine vision. And so, this a whole new field of effective computing that is coming into play, and I think Alistair mentioned this conversational analysis, emotional AI. I mean, there are many new features that will come into play to sort of do a variety of things, whether it's enhancing diagnosis, providing early insights. Obviously this is non-invasive. And then of course, through that, the opportunities around building digital therapeutics once you get that early assessment. So I just think that, given, we should, if we're going back to this sort of, how did the pandemic change things? Well, it changed things because it may really impact the ways in which providers and patients are interacting. We shouldn't see that as an obstacle or a less effective way of communicating. We should see that as a huge opportunity in terms of the massive amount more data that will come up in these engagements. And I think the amount of innovation and startups and new IP that will be generated is going to be outstanding. So that's what I'm quite excited about. And I think maybe it's a little far out, but I think it's within reach over the next several years.
John, do you think that it will change the way we design our buildings? Like, in other words, there's a very traditional approach to build in, a new hospital or a new clinic. They sort of have waiting rooms, which one could argue, why do you need a waiting room? There's maybe better ways to do things than have large waiting rooms.
Yeah.
But even in terms of in a hospital room,
yeah.
that typically today has a bed and stuff like it, should there be ambient technologies that are just built in? Right?
Yeah, we're doing that now. So we're Boston Children's is putting up a new building, and it's very hard to brainstorm these things, as how do you build something for the future that you don't fully understand will be there. And so yes, we're trying to account for some of these things like ambient listening or other sort of features of data capture. But then there's the whole realm of things you just have no idea about, and so we're trying to create flexibility and just making sure that there's the internet and Ethernet is there in ways in which we can take advantage of whatever those things are we don't know. But yeah, I mean, I think you're absolutely right. I mean, we need to be thinking about the new types of vital sign, we're calling the fifth vital sign in some ways, but like other ways of the data that we have not been sort of thoroughly capturing in the past. So yeah, I'm sure you're thinking about these things as well.
All right, well, we have about 5 minutes to take some questions. So just a reminder to everyone that you can put some questions into the chat box. I've seen some coming in. One question, I'm going to try and quickly summarize it, but it basically has to do with so many different technology players in the industry. How do we quickly find value from that and sort of rapidly determine which ones are best in class so that providers and patients can benefit more quickly, kind of reduce the clutter here? I open that up to any of you.
It's a vexing problem because you do end up with fragmentation. If like, in other words, the wonderful thing about my colleagues at Mass General Brigham is it's not for want of ideas. There's a lot of innovative ideas that are coming every single day but the issue is, how do those ideas scale in such a way that you end up with a workflow to the patient and to the provider and to the staff that is not so fragmented that you end up burning them out? So that's the challenge. Is it's finding the best in class in terms of what's the favored of a specific type of technology, but it's also making sure that it actually works beyond what is imagined or invented to something that actually will work locally on the front line that will actually add value, reduce cost, improve quality, and not introduce fragmentation of an experience, whether it's the patient or for the provider.
Yeah, it's such a good question because it's very easy to get, you know, very excited about shiny objects and then just have this like massive environment of a lot of pilots, which I'm sure Alistair deals with constantly. You know, there's always the next new shiny thing that we want to go after. And I'm guilty of it for sure myself. I mean, there's plenty to do. And the question is, can you sort of take some opportunities and go deep with them, even if, because of course, it's easy to sort of sign an agreement, but to go deep in a hospital implementation is a whole other story. And so we've tried to be much more disciplined in that approach, both through figuring out the real sort of pain points that we need to go after that are set by the administration, but then also going after meaningful relationships, and that means saying no to a lot of things. And it's challenging because we want to do it all, but that discipline right now is so critical if you're going to get the most amount of value through these partnerships.
The only thing I'd add is that, for those of you who were like, this is not my full-time job and I just like to learn more, John and Alistair are vetting like some of the most cutting edge startups. But there are industry groups who do try to, evaluate things. We might all be familiar with best in class, although they generally evaluate more established players. So not as helpful if you're thinking about innovation. But there are also some groups like Avia based in Chicago, just a consulting firm. They go out, do deep vetting, and they provide deep due diligence to their members. And so it's almost like a consulting, relationship where you get like that advisory role if you're thinking about a pain point. And there are other organizations like that are, that do that. They say, let me go find the best in class for this pain point. It might be patient access or prior auth or, clinical throughput. And they will go and try to provide some of that. So there are some of those resources available, if you're not an innovation center, you aren't, an expert in this area.
Great. Now I have a question about COVID, and there's been a lot of concerns about mental health, especially for children who are not in school right now. Any thoughts about the role of technological innovations and health institutions to problem solve here?
I mean, I'll just quickly mention, behavioral health is a huge priority for our institution. There was already a challenge with getting good access for patients just because, there's more need than capability to serve the entire patient populations out there. So we're investing a lot of our work both in sort of innovative sort of digital tools. We actually, the hospital did an investment in a company called Brightline, which is really thinking about new approaches to serving the long tail of patients in the pediatric space that need behavioral health therapy through both brick and mortar clinics, but also through digital tools. And I think, we've seen this massive rise in innovation and investment in this space because, of course, there's the complex patients that need sort of a lot of in-person care, but then there's the broad set of patients that I think could benefit from sort of digitally enabled tools that are more accessible, cheaper, available at home, especially during the pandemic. So yeah, I think that's a great question. And I think, again, this is one of those examples where the pandemic has a sort of forced our thinking in certain domains, also recognizing that, a hospital could potentially get super disintermediated in some of these domains if we don't move fast enough to provide more access to patients. So yeah, absolutely a major priority.
Great. And then last question, because I know we're right up against 2 o'clock. How do you ensure that new technology doesn't, that everyone can access it, and particularly with older patients that they might not be in tune with cutting edge systems?
I think it's just not a one size fits all. I don't think you can take something like a portal or something like that and just assume that every single patient is going to be able to log in and connect that way. I think they may be differentiated answers depending upon the kind of patient. So I think it's just, and that's kind of back to the sort of digital divide concept of really making sure that whenever you introduce a new technology, that you take into account all patients and capabilities, not just the ones that are endowed with the right set of technologies, and to kind of try to narrow that digital divide over time as opposed to make it larger. And that means that sometimes you're just not going to be able to provide everybody with all the bells and whistles that would otherwise exist. You know, a text and platform, you can only do so much. But it's important to include it as part of the deployment, just to make sure that we don't leave anybody behind in what we're doing.
Great. Well, thank you very much to our panelists. That was highly informative. Kirsten, I'm going to send it back to you to wrap up now.
Okay, thank you, Kathy. I'd really like to thank our panelists today. This was a fast-moving discussion. We definitely had more questions than we could get to. So hopefully we'll continue our discussion on innovation, which is definitely our plan in 2021. Very excited to see such a great local representation of the talent and dedication and drive that we have in healthcare to really be the best. So thank you again, and we will see you next time.
Thank you.
Thank you.
Thank you.